I have a question for Professor Maron. As we know, your entire family has contributed so much to cardiology, especially on hypertrophic cardiomyopathy. In your early career, or during your father's era, how did our understanding and the management of cardiomyopathy differ from today? And after there are any landmark moments you'd like to share?
Sure. Well, first of all, I'd like to just start by saying that it's an honor to be here among this esteemed group of colleagues, and also the opportunity to share our thoughts on hypertrophic cardiomyopathy through this forum for Quest for the Truth at OCC. So I want to thank you for that opportunity. This is a great chance to kind of dive a little bit deeper into the topic, to really have good discussion that sometimes we don't quite get the opportunity to have with the normal lectures. So this is a great forum. So thank you. I'll start by saying that I've had the opportunity to see, I've been fortunate, I should say, to have the opportunity to see the evolution of HCM over many years and decades. I think one major point I'll make about the past versus now is really the application to HCM of therapies, contemporary cardiovascular therapies, including the emergence and application of surgery for relief of obstruction, followed by alcohol ablation to reverse heart failure. Of course, the treatment of atrial fibrillation and stroke prophylaxis with anticoagulation, drug therapy that has emerged, of course, recently with cardiac myosin inhibitor therapy to improve symptom burden in obstructive HCM, and a mature risk stratification strategy to identify those patients with HCM that are at high risk for sudden death and to protect them with an implantable cardioverter defibrillator. If you kind of take a look at all of that and how it's impacted over now many years and decades HCM, we've really been able to, in a way, transform HCM from what was a scary, high-risk, morbid disease to one that we would consider today to be highly treatable. For most patients, the opportunity with those treatments to achieve normal or near normal longevity with also a very good quality of life. And that's what we can provide the vast majority of our patients today, where that wasn't, of course, the case if you go back now 10, 20, 30 years ago. So we've really made a huge progress. Obviously, we have more room to go. Still, it's not obviously where we want it to be in terms of certain unmet needs, which we can talk about. But in terms of the transformation up to this point, it's been unbelievable in my mind. And that's probably been one of the biggest observations that I've seen. In terms of the landmark moments, I think there's been a number of landmark moments, that I'd probably point to in HCM, going back to Dr. Brunwald, who, as we know, the grandfather of cardiology with so many seminal discoveries, but one of his most important, of course, was his clinical description of HCM to begin with. And that started the whole story of HCM, of course, with his description of the first 64 patients with hypertrophic cardiomyopathy, putting that disease for the first time on the map, and that was in the early 1960s. And that ultimately led to certain treatments like surgical myectomy and the evolution of that operation over many decades, as well as its alternative, the alcohol septal ablation. We have, of course, as I said, the maturation of a risk stratification strategy and the ICD to HCM, which was again another landmark moment, applying the ICD to a genetic heart disease to prevent sudden death was really a transformative moment in a way. And of course, obviously, the identification of HCM as a genetic heart disease, in which we now know, of course, there are mutations, many of them of the cardiac proteins of the cardiac sarcomere responsible for HCM, but unifying HCM as a genetic disease through the the Christine Seidman laboratory at Brigham and Women's Hospital, initially identifying that first sarcomere mutation. And then, of course, I'll conclude by saying, of course, most recently, the evolution and emergence of a whole class of new drug, cardiac myosin inhibitors, and their impact on obstructive and now potentially non-obstructive HCM obviously has been a huge breakthrough, providing now many, many more patients the opportunity to achieve a improvement in how they feel with drug therapy is a critical breakthrough moment as well.
Yes, Professor Maron, just as you said, the emergence of CMI gave us novel treatment options for
Right.
HCM patients.
For sure.
But also come with many more new questions.
Sure.
And this morning, we already had the opportunity to discuss with you of 10 key questions that had been collected from Chinese experts. However, the discussion was very inspiring, and we still feel there is much more to explore with you. Our team would therefore like to take this opportunity to ask you a few additional questions.
Let's do it.
And hear your insights.
Yes.
In clinical practice, we do encounter some HCM patients test negative for conventional sarcomere gene mutations. Do you think this genotype negative HCM and classic genotype positive HCM are fundamentally the same disease? Is there any difference in their pathogenesis and management?
Yeah, it's a great question. I think fundamentally, they are the same disease, right? I think we have to look at them the same as it pertains to management. Okay, we certainly look at them when we're talking about risk stratifying and of course medical treatments, including CMIs, are applicable to sarcomere patients with sarcomere mutations as well as those without, as long as they have a clinical diagnosis of HCM. So I think it's the same disease. I think what we do appreciate is that there may be slight differences in the outcome if you have a sarcomere positive mutation versus if you do not. Okay, so outcomes may be a little bit different. That doesn't mean that if you don't have a sarcomere mutation, you're not at risk, of course, of potentially adverse complications like sudden death or progressive heart failure. You are, but I think it's really, essentially it's just a little bit less on whole than if you have a mutation. Okay, and so I think that's probably the biggest difference. I'll also say that. And again, this is something that I think is also going to be an important issue for the future, is understanding and clarifying better what is responsible for the common phenotype in those without a sarcomere mutation. Okay. I think we're starting to understand that a little bit more now. There's some suggestion that there's variants, that there's a polygenic, multiple variants may contribute to the disease as well as environmental factors. And I'll just say, I think we have a lot of work to do in terms of environmental factors. I think that's another area that we really haven't really understood very well. It's the impact on environment on disease expression, particularly in the sarcomere negative patients as well.
What advice do you have on exercise and rehabilitation for HCM patients? And the other questions, and how should physicians get patients physical activity? In addition, for young patients hesitating between lifelong medication and septal reduction surgery, how do you usually counsel them when making these decisions?
Sure. Yeah, I think we always want to ensure that we're providing our patients the right recommendations around staying healthy with HCM, of course, and part of that is recommendations around physical activity. And I think what I'll say is that we have always said, and the guidelines have always supported this as well, is that for nearly all patients with HCM, mild to moderate, recreational level aerobic activity is not only permissible, but should probably be encouraged to allow patients to maintain, healthy cardiovascular status as well as mentally as well, by being able to be physically fit. So mild to moderate recreational level exercise has been always part of what most patients with HCM can engage in and should engage in. I think we've had a little bit of, differences in terms of how we may be looking at more vigorous physical activities than that, where I think you probably should have a, individual assessment if you're an HCM patient with respect to if you want to continue to engage in really vigorous physical activities like competitive sports, that's a discussion where you should have that with an expert HCM provider to determine whether that is safe or not in terms of a recommendation. So, that's kind of how we do it. And I'll just say, getting really practical here, what I say to patients with HCM is mild to moderate recreational level activity is fine, so that at peak exercise, generally what we say is that it's not about a heart rate number, it's about the intensity, so that if they are able at peak exercise to have a full conversation without straining to complete words or sentences, that's usually where we want them to be, staying well hydrated as well. And that to me is safe, but also balances the opportunity to stay cardiovascularly fit.
东方问道。